Good morning. Good morning to all. It is 10 o'clock, so about ready to start here. So if folks could take their seats, we'll get underway. I'm trusting that folks on the Zoom are able to hear me as well. Yeah, I see a couple of heads nodding there on the Zoom. So good morning to those here in person and those joining us on Zoom from across the state. The Tennessee Healthcare Campaign is a nonprofit, nonpartisan organization working for over 30 years to promote healthcare justice in Tennessee. We believe that all people in Tennessee deserve affordable, equitable, quality healthcare, and we advocate for programs and policies that improve the health and well-being of Tennesseans. My name is Richard Hennigan. I'm the current chair or president of the THCC Board of Directors. I'm a retired family nurse practitioner. I spent almost all my career working in what we now call safety net clinics. I'm very proud of the work that I did there and that my colleagues did in those clinics, but I'm engaged so much with the Tennessee Healthcare Campaign because I know that those clinics are not a scalable solution to the problems that we are trying to address for healthcare justice in Tennessee. I want to also introduce now our Executive Director, Judy Reutemann. Judy has been with us for over 2 years now, and we like her a lot. She's a great worker, a great ED. So welcome to our 2023 annual advocacy conference for the Tennessee Healthcare Campaign. THCC has been having conferences in East Tennessee since at least the mid-1990s. I can remember those conferences. But as I best recall, we started doing an annual larger conference in the mid-noughts. So I think this conference is nearing our 20th annual advocacy conference. We're glad to be here today in East Tennessee for 2023, where we have had and continue to have great volunteers and supporters. We are having a live only, sorry you folks on Zoom, but you won't be able to participate in the silent auction today. The items in the silent auction are on the tables on my left, on your right, over there. And we hope that you'll take a few minutes several times a day to go over and look at those items and keep up your bids to get the bargain you just have to have on each of those items. Participants here today on Zoom and live are able to be eligible for social work and nursing CEUs. To receive your CEUs, you must have signed in. You must have registered to get the CEUs when you registered for the conference. You have to sign in attendance at each presentation. So people signed in when they came in today for the keynote address. So that's done for those who are getting CEUs. When we break into the two groups, we'll divide this room up and we'll have a group in each in the morning, and then after lunch again a group in each, and then we'll be back together for the final large group meeting at the end of that time. But for each of those other sessions, there will be a paper circulated that you will need to sign in, those who are in the room who are getting CEUs, so that we can properly document that you're here if the CEU providers ask us to do so. If you're online, if you're on Zoom, we ask you for each session to sign in to the chat. You can just say hello or just whatever you want to write, so we know that you're there at the beginning. please leave your camera on for the entire session. And then remember to do that for each of the sessions, including this one, because you all didn't sign in when you, as the people in the building did. If you have any questions or problems with the CEU process, I'm going to ask you to consult with Dr. Georgita Washington, who I will presently introduce to you in a few moments. I want to take a moment to thank our sponsors for making today possible. We've been seeing their logos on the circulating slides that have been up in the room here, and I've been on the Zoom. I want to especially thank the equity level sponsor, which is the Division of Health Disparities Elimination of the Tennessee Department of Health, which also funded THCC's Vaccine Equity Project over the last year. We are very thankful for their generous support. Our innovation level sponsors are the Tennessee Disability Coalition, and I'm hoping to show a little video here. Logan, I think you're going to have to come up and help me out, because clicking, oh, no, there it goes. Logan, how do I get the TV video to go away? All right. Okay. So the Tennessee Disability Coalition, the Tennessee Association of Alcohol, Drug, and Other Addiction Services, TADIS, Cherokee Health Services, Oak Ridge Associated University, Tennessee Hospital Association, United Auto Workers, Region 8, Vanderbilt School of Nursing, and the incomparable Merle and Randall Rice, who are innovation level sponsors on top of everything else they do and have done for the Tennessee Healthcare Campaign. Our access level sponsors are Tennessee Charitable Care Network, Tennessee League of Women Voters, Tennessee Justice Center, the Tennessee and Alabama area United Auto Workers, the National Alliance for Mental Health, NAMI, Louise McCowan, who is here, and I think probably represents the longest active member of THCC in the room at this point. So Louise is over here. Thanks for attending today, Louise, and thanks for all you've done over the years for THCC. And Ann Child, who is here representing Results. So Results, the organization Results, is the access level sponsor. We are also grateful for the continued support of the many other organizations and individuals listed as sustaining sponsors and friends. We thank them and all those who contribute time, energy, and financial support to this conference and to our work. Anyone associated with one of these sponsors, please stand in the room or raise your hand on the Zoom. Please, all of us in the room and on Zoom, join me in giving a huge round of applause to all of our sponsors today. A complete list of the conference is on the conference packet and on our website. I want to introduce the THCC staff. I've introduced Judy, our executive director, Sylvia Calzadilla, the director of enrollment services. You could, if you don't mind, stand for a moment when I introduce you. There's Sylvia. I don't think Tom Savage is here. Is that, yeah, is he here? No. Well, Tom Savage is our outreach coordinator. Susan Veal, our office manager. Susan, stand up. Oh, she's still out there. Okay, Susan, is from Murfreesboro and works part-time, and she deserves a great round of applause for all her contributions to make this conference work. This one and all the ones that she's been involved with over the years. Priscilla Morales is one of our insurance agents. Priscilla is over here. And Lacey Lyons, our Storybook coordinator. There she is. Lacey, you want to stand up for a second? Yeah. Lacey's our newest employee. We have a very small staff and very large ambitions. Our organization's success is due to the incredible commitment of time, talent, and resources by our many volunteers. I want to ask all the current and past board members to stand or raise their hands on Zoom, and likewise all the enrollment, advocacy, and vaccine project ambassadors and volunteers that are here or online. So if those people would stand, and I want to acknowledge them as representative of all the other volunteers that THCC relies on. I want to thank the planning committee for this conference for its hard and effective work under the leadership of Dr. Georgina Washington. There she is. Thank you, Dr. Washington. And if you have a question or a concern, she's the person to ask if you're in the room, or send her a message online if you have a question about the process for the CEUs. And the other members of the committee who are here, please stand or raise your hand on Zoom. Tracy Stansberry is here. Paige Hudson is online. Amanda Letherin had a sudden death in the family and is unable to attend today. We'll send our concerns and thoughts and prayers to her and her family today. Judy Reutman has been on the committee, and Susan Turner also, who is here in the room. Where is Susan? There she is. Thank you, Susan. The work that THCC and its many allies and supporters do is hard work. And the events at the Tennessee General Assembly this past week are a good example of how discouraging this work can become. Nevertheless, the folks who gathered at the General Assembly don't seem ready to give up. And I trust that those of us gathered here today live and on Zoom aren't ready to give up either. And in fact, I feel, at least for myself, that we may in fact be seeing this planting of the seeds of a new and more just and healthier Tennessee in these times. So let's now get on with the conference. I am honored to introduce Dr. Leighton Koo. He's professor of health policy and management at the George Washington University in Washington, D.C. He directs the Center for Health Policy Research there. It's a large multidisciplinary institution focused on the issues that are central to THCC's work. Excuse me. He has more than 25 years of experience with both all levels of academia and with many of the most respected core governmental and nonprofit health policy institutions of our nation. He will engage us today on the topic, the economic benefits of Medicaid expansion. Thank you, Dr. Coons.
Thank you very much. And this is your, and let me just check. This is the mic, and then how do I get to the slides? Help.
I think that's the video in here. Which of the screens is the slides?
I think I don't have it up yet. Hang on a second.
All right. In the meanwhile, thanks for having me here. Thanks. I'm amazed when I heard Richard talk at all the people who've worked for the Tennessee Healthcare Campaign and to just get this meeting organized. So thanks for inviting me. I haven't been in Knoxville before, but it's lovely to be here.
The desktop. No, I don't need this. I need the desktop.
I just taught my first class of the semester on Thursday night.
7.
So I'm sort of used to these problems of fumbling with technology as we try to get things to work.
Is that everything?
Here we go. Thank you.
On one hand, technology is a blessing. On the other hand, it constantly befuddles us.
It's like, oh,
Probably want to go to slide show at this point.
Centering the camera on them.
yeah.
There you go.
If that works and people can see this, oh yeah, good. And hopefully I can just advance this and this will work.
I get your face a little better.
Yeah, okay, good.
Yeah.
Trying to get. So anyway, so thank you very much for inviting me here. So my name is Leighton Koo. I'm a professor at George Washington University. I've been involved in doing things relating to Medicaid and access for care for many years. And part of the reason that I think that I was invited here today was actually I've been doing research and work with North Carolina Medicaid expansion for about the past 10 or plus years. And in fact, I've been involved in doing things with Medicaid expansion for a number of years, even before the Affordable Care Act was passed. But part of the reason why North Carolina is of such interest is it is like Tennessee, okay.
Zoom master here. Sorry, my apologies.
Like it's another southern state that has not expanded Medicaid yet. Hopefully we find ourselves close to being on the brink. As you probably know, this year they passed legislation that will expand Medicaid in North Carolina. After many years, it is still pending. The budget has to be resolved between before it goes into effect. But there was a situation where the Republican heads of the Assembly and the Senate came to agree that this was a good idea, and so joined with the Democratic governor to say, let's try to make this deal work. So it's taken a long time, but they're getting close there. Okay, now, good.
Keep going. I'm sorry.
So it's okay. Anyway, so what I'm going to talk about today is, first, I will say I was here to come talk about the economic benefits of Medicaid expansion. So I'm going to talk about some economic things. For those of you who are not numbers oriented, I apologize. It might be in that case a little dry. On the other hand, what I'll say is I think the reason you brought me here is that historically the way that people have approached Medicaid expansion is to talk about the moral reasons for doing it, the health reasons for doing it, why it's just the right thing to do. However, that doesn't persuade everyone. So the rationale for trying to say it also makes sense economically and financially is important to convince people, because I've been involved in public policy for a long time. I realize the cost of things and being able to finance things is a critical issue in government today. And it helps sort of persuade some of the people who could be persuaded that this is something that makes sense. And again, in the case of North Carolina, that actually seems to have made a difference. After talking a lot about that, then I will briefly go through some of the things that we know about the health and social benefits of Medicaid expansion. I was asked to comment on some other issues that are coming up. I'll talk briefly about work requirements, and then finally about sort of, how hopefully we can get to the stage, both in Tennessee and across the country, of trying to move past this as a partisan issue and really trying to make this something where we realize that this is something that has very broad benefits on the left and on the right that we can appreciate. So let's see if I can now. Trying to advance the slide. Let's try it this way. There. So here's some Medicaid basics of Medicaid financing in Tennessee. So for those of you who don't know some of the ways that these things work, Medicaid, or 10-care as we know it here, is basically financed jointly by the federal government, by the state government. The key formula as far as the financing, the economics goes, is based on what's called the federal medical assistance percentage, or the FMAP. It's the federal match rate. So in Tennessee right now, for most benefits, the federal government covers about 2/3 of the cost. Specifically, right now it's 65.3% of the cost, and the state is responsible for covering the balance. And so that's the basic gist of it there.
I've broken it.
Well, it's still on the screen, so that's what counts.
Nope, I made it worse. Why is your presentation gone now?
No, it's there on the screen, and it's here. Okay,
Maybe.
all right. Anyway, so in other states, the federal match rate varies a little bit. In many states, wealthier states, it's 50%. In Mississippi, it's 77%. But anyway, then for the Medicaid expansion, part of the legislation of the Affordable Care Act basically said the federal match rate would be higher. So the federal matching rate under the expansion for people who become eligible under that expansion, so that would be taking from the current 10-care eligibility up to 138% of the poverty line, there the federal government will pay 90% of the match rate. And so the gist, essentially speaking, is the Medicaid program grows, federal financing grows, and so there's more money that's brought in to support healthcare that way. The state also has to bear some portion of that cost, but it's really the minority of that cost. Now, I will say conversely, when the Medicaid program shrinks, then enrollment falls, costs fall, and in that case, the federal government provides less revenue to the state, and the state saves some money too. So once again, let's see if the advancing work correctly. So as you do know, Tennessee has not expanded 10-care. And so because of that, the Medicaid eligibility rate for adults right now stands at, and hopefully my statistics are right, around 78% of the federal poverty level. For a family of 3, that's an income level of a shade over $19,000 a year. If Tennessee did expand Medicaid to the federal standard, 138% of the poverty level, then in that case, the income eligibility would go up to around $35,000 for a family of 3. So Tennessee, by virtue of having stuck with its old rate for a number of years, basically has sort of been kept from getting that 90% match rate. And in addition to the fact that it means hundreds of thousands of people that haven't been able to get coverage, in addition, the federal government has not been providing as much funding as it might have provided. So the net effect of that, and I didn't do this calculation, this is sort of a rough ballpark, is Tennessee has lost about $20 billion or more in federal funding over, roughly speaking, the past decade. These are funds that could have come to Tennessee And in fact, so then you find that the sort of peculiar situation that tax revenues that Tennesseans pay to the federal government and their income taxes actually go from Tennessee and go to other states. And so they're going to California, they're going to New York, they're going to Kentucky, they're going to Arkansas, they're going to other states. They will hopefully will soon go to North Carolina. And so Tennessee has, essentially speaking, been sort of depriving itself of these funds, which is something that I think, typically speaking, people in the state government would think, gee, this isn't such a good idea. That in addition to this, there's some substantial economic repercussions, and that's part of what I want to talk about. So this is, and I apologize for this, is sort of a busy slide. So this is talking about what we call the multiplier effect. And so the way, really the key aspect in Medicaid is how much money is the federal government and the states contributing together to spend for Medicaid, which therefore goes from where I have it, and I don't know if you can see my arrow, no, you can't see the arrow, sort of towards the, whoops, I made something disappear. Oh, back again, oh, thank God. Anyway, so there's the total amount of spend that's spent on Medicaid. The federal government adds in its federal matching revenue. Now, however, the total amount of Medicaid spends goes to healthcare providers. That's really the primary source. There is some that goes to other things, but mostly it's going to hospitals, clinics, pharmacies, and so on. So it's providing that direct subsidy. So what we talk about this in economics terms is we say that's the direct effect. So this direct effect of an injection of billions of dollars. And in this case, really what I want to concentrate is on the federal share. The state is doing something, the state would do other things with those funding if it wasn't being spent on Medicaid. So really what we're talking about, the fact that the federal government is pumping in extra money that the state would not otherwise have. And that's a direct effect. Then next, healthcare providers employ staff. So they have staff that they're paying salaries to: doctors, nurses, social workers, pharmacists, et cetera. In addition, they buy things, they pay for rent, they pay for computer services, they buy medical equipment, and so on and so forth. So they are spinning off business. So when that money first comes and stops off at the healthcare providers, then it makes another step as it goes down to staff and to other purchases. So that's what we call the indirect effect. But then it keeps going, because what happens when you pay wages to people and they get their salaries? They go out and they buy groceries, they pay their rent or mortgage, they maybe will take a trip to Graceland for some, some visits. So they're doing things that consumers do that contribute further to the economy. Similarly, when they go, when hospitals and clinics and so on and so forth spend money on other equipment purchases, other purchases, they pay their staff, they go buy things from other services. So then in effect, that's the sort of the final multiplier effect, when the money keeps on generating over and over through the economy. And I will say in the end, all contributes also to state and local tax revenues. So the net effect is that when Medicaid grows, then federal revenue comes into the state, and that contributes to growth in the state, and that contributes to economic growth in the state and also to employment growth. Conversely, when Medicaid shrinks, and I'm sad to say part of the thing I want to talk about today is also Medicaid shrinking, because we're going through the unwinding right now, then we see the reverse effect. Then federal funding is withdrawn from the state, and that basically means there's some downward economic consequences as well. So more funding of TennCare was expanded under the ACA. And so obviously the first thing that would happen is more people would get TennCare. The estimates change from time to time. I'm not necessarily sure this is exactly the right one, but the estimates I saw would say maybe roughly 330,000 more people would get TennCare. That's not necessarily more than right now. This gets a little messy because of this unwinding situation that we're in right now. But anyway, there would be growth. Because of that, the federal government will add more money, will contribute more. And again, it's at this higher 90% match rate for most of the new people who come on Medicaid. There would be some people who were eligible already. In many cases, we talk about a woodwork effect, where children, for example, who are already eligible, come in when their parents come in also. And so the state, however, would have to sort of put up its share of the match too. So there is some cost to the state. And that's part of the reason why state budget people often object to a Medicaid expansion. They say, where are we going to get our share? Where are we going to get our 10%? In addition, I will comment that what will happen is if Medicaid was expanded, some of the people who were in Tennessee are right now getting health insurance through the health insurance marketplaces, the Obamacare marketplaces. They get federal premium tax credits for participating in that. But if they shift over from the health insurance marketplaces to TennCare, then there's some reduction in the federal tax credits that are currently going to there. So there's a little bit of loss of federal revenue that happens because of that. On the other hand, one of the things, and this is an important element, was soon after COVID came in, there was a new piece of legislation called the American Rescue Plan. Now, under the American Rescue Plan, and this was a deliberate effort by the federal government and by Congress to basically, we would like to give an incentive for the remaining states who have held out against expanding Medicaid. We want to give them a bonus, a financial bonus. If you sign up for and you expand Medicaid, then for 2 years, we will give you an extra bonus payment. So it's sort of like a hiring bonus when you give someone to come on board. That basically speaking, will give you 5% of your regular Medicaid expenditures. This is not just the people who are newly eligible. This is 5% of basically your whole Medicaid budget. And she'll get that extra, roughly speaking, for 2 years. So this is where we now get to the all the numbers. So these were the analyses, and I'll say these were analyses we did a couple of years ago in 2021. So are they exactly right for today? I'm not sure that they're exactly right for today. They'll be somewhere in the ballpark direction. So anyway, if full expansion occurs in TennCare, we would expect that, roughly speaking, 300,000 more people would be enrolled. And because of this, there's an additional expenditure of that. And the federal government, when it has to cover the additional cost of the new TennCare enrollees, would contribute about $1.8 to $1.9 billion extra per year. And this, because that 90% match rate is written into the federal law, that will continue to go year after year. In addition, there's that bonus payment. So the American Rescue Plan gives a bonus payment. So the bonus payment would last for 2 years. We calculate would be somewhere on the order of $600 to $700 million per year. That'll last for 2 years. So it doesn't last forever, but still is a bonus that happens if you come in right now. There's a slight loss of federal tax revenue. So because of that loss of the federal premium tax credit, federal revenue would fall by around $280 million. But the net overall effect in terms of the federal government is the federal government would be contributing about $2.2 to $2.3 billion extra into Tennessee for the first 2 years, a little bit less after those first 2 years. So that's the new federal funding that's coming in. Now, again, from the state's perspective, the state's saying, hold on, we're going to have to pay something too. And that is typically speaking what state legislators and the governor complain about. They say, what about our share? Where are we going to come up with this? So our estimate suggested that the state's cost for matching the new enrollment in TennCare would be, roughly speaking, a little over $200 million a year. And so that would keep going. Again, it's going to last on an ongoing basis. But in addition to that, because of that multiplier effect, we'd expect to see some growth in state and local tax revenues. And so there we were estimating, and this is a little rougher estimate, about $70 to $80 million per year extra revenue that comes into the state because of the economic growth that occurs when we expand Medicaid. So the net effect is that from the state's perspective, the state local cost is really around $140 million a year. So if you consider the federal government is going to add $2.2 to $2.3 billion a year, the state's going to have to spend maybe another $140 million a year. The truth be known, Tennessee is getting a massive windfall. Tennessee will get a windfall of around $2 billion a year in the first 2 years, maybe around $1.5 billion extra federal funding in the years thereafter. And again, these are not exact numbers. At some point, we did these a couple of years ago. If I had to do them again now, I might re-estimate it. And in addition to this, when the state people have to estimate it, they will come up with estimates. So we slightly, but hopefully close to this. So the next part is then sort of what are the broader economic and employment effects? And so that's where that multiplier effect comes up. This part here is all what the state budget people are concerned about. This is how much is the state going to get in extra federal money? How much is the state out of the state budget going to have to pay? So this is the part that's traditionally been the big hangup in Medicaid for many, many years. And part of this is, of course, what people who are critics of Medicaid will say Medicaid is also already costing the state an arm and a leg. And you're asking us to put more money in. So the answer is the reason you put more money is because it's a good investment. Because in the end, you bring in so much more federal funding than you're going to have to spend on the state side of things. And so that really is undeniably. And so in North Carolina, this is what squared the deal in North Carolina. This is what helped contribute to the deal in other states of saying, yes, we realize this is financially a good deal, particularly because of that American Rescue Plan bonus. That basically means in the first 2 years, the state would have to spend some extra matching money, but the state is actually making money directly into state coffers because of that ARP bonus for 2 years. And you'll notice, because it's roughly $600 to $700 million a year, that's way more than the $200 to $300 million in the state cost. So it actually sustains that Medicaid expansion for a few years. All right, so that's the direct fiscal effect. So that's what the state budget tends to be concerned about. Next are some of the broader economic and employment effects. And these are based on sort of economic models that are used widely. We use a model called, from a company called Regional Economics Models Incorporated. This is sort of considered the sort of premier model to do this thing, to understand the economic consequences. So it goes to that whole multiplier, basically tries to emulate what happens when you add that extra money into Tennessee's economy. You put it through healthcare, where then it filters through the rest into staff, for healthcare staff, into other purchases, and so on and so forth. So at this point, what we'd say is the total gain in the state economy, and here I define this as the state gross product, and this is actually a fairly conservative measure, is around $5 billion per year. So the state economy would grow by $5 billion a year in those first couple of years, a little bit less in the years thereafter. What this means is because there's more money that's being injected into the economy, businesses have more money to hire people. And again, we would know that hospitals, clinics, and so on and so forth would actually need to have some more staff. But so altogether, we would expect, roughly speaking, 43,000 to 44,000 new jobs in Tennessee in the first couple of years. Again, a little bit less thereafter. Now, it's not on healthcare. That's the other thing, is most of you here, or many of you here, are involved in some manner, shape, or form in the healthcare sector. So every now and then, if you are someone who's not in healthcare, if you're in finance, if you're in manufacturing, if you're in agriculture, you basically would say, what is in it for me? And the answer is, but the majority of job growth is actually not in the healthcare sector. What we estimate is around 25,000 jobs, would come in other sectors of the economy. So that's all those other sectors: construction, finance, not a lot in agriculture, not a lot in manufacturing, but some. And it's because people go out and are buying more things. So they're buying more groceries, they are paying more in their mortgage, they're paying more in their rents, they're buying new cars, and that contributes to overall economic growth, not just in the healthcare sector. And that's why the majority of growth occurs elsewhere. Again, so it's a good economic stimulus. Well, thanks. In addition, when we've done analyses of this on a regional basis, we basically find it helps all parts of the states. In North Carolina, one of the things that we did that actually was particularly helpful, we did a county by county analysis, and we can show basically in every county in the state, there would be an economic bonus. And I'm told that was very useful in convincing legislators who could be told, in your county, this is how much growth we think there's going to be. This is how many new jobs we think there are going to be. This is how much this is going to help this specific county. And of course, for a state legislator, that counts a little bit more than you say in general, this helps the state. If you can say, in your town, in your county, this is what the impact is. So that's Medicaid expansion. Unfortunately, right now, we are in a slightly different situation in Medicaid. I'm sure that many of you have heard about this problem called Medicaid unwinding. And so if you haven't, forgive me for a moment while I give a little bit of backstory. So during the COVID pandemic, so soon after, in early 2020, people realized, oh my God, COVID is going to cause a massive disaster in the country. And you may recall in the early 2020s, everything was shut down, unemployment rose. Suddenly, state agencies were not able to function because staff weren't coming into work. And so there were a number of problems that occurred. So in response to this, Congress said, we're going to give states some extra money. So they basically said, we're going to increase the federal matching rate by 6.2 percentage points. Now, some of this was to help Medicaid, but to be perfectly honest, and I've been involved in designing Medicaid fiscal relief measures back in the 2000s also when I was at the Center on Budget and Policy Priorities. Some of it is to help Medicaid, but a lot of it is to help the state in general, realize that states have to run balanced budgets. So if we can do things that help bring more federal revenue and reduce state costs, that helps the state budget in general and helps the state sustain situations where there's serious economic downturns. In return, the deal that was set up in the legislation was states have to agree that they're not going to cut anyone off Medicaid during the time of the public health emergency. So there had to be what was called a continuous enrollment period. So for the past few years, no one was cut off Medicaid until just recently. And so that just the public health emergency and that period just ended. So the data that I see indicates that between March 2020 and May 2023, TennCare grew by about 1.4 million, from about 1.4 million to about 1.79 million. So it grew by about 370,000 people enrolled in Tennessee. Now, what this means is the combination of new enrollees, and they were getting, again, a relatively high match rate, or the regular match rate, but they got that extra 6.2%, basically meant that all this was fueling more federal money coming to the state to help it during the time when things were a little rough. So this was something that was comparable in a way to Medicaid expansion, not quite as generous as the Medicaid expansion would pay, but was helping the state during the past few years. Unfortunately, this was a temporary measure, and the temporary measures had to end at a certain point. So for those of you who realize the public health emergency as declared by the federal government has ended, in fact, for Medicaid, it ended just a shade earlier because of some changes in legislation. So now we're at a situation where all across the country, including Tennessee, states are beginning to do what's called unwinding. In the unwinding process, basically speaking, for all those people who came onto Medicaid, so all the 1.8 million people on TennCare right now, the state is, over the next year or so, will have to redetermine eligibility for each and every single one of them. And if they think that they're not eligible anymore, they will discontinue Medicaid. Well, we've learned already in a number of states, and I can't swear that that's what's going on in Tennessee, but in many cases, we're seeing hundreds of thousands of people being dropped off Medicaid. I don't think it's been quite that big in Tennessee yet. I'll get to some statistics that I have in a moment. But in many cases, they're being dropped off for procedural reasons, of which the major reason ends up being the state would send a letter to someone's house saying, we want you to renew your Medicaid information, but the state didn't have their address. So because the state didn't know where someone lived, the person never responded. Or in some cases, they may have successfully contacted someone, but the person did not respond back to the state. So because of this, what we've seen going on so far is that in many cases, the major reason people are being dropped off for Medicaid is for procedural reasons. It's not that they're actually ineligible. We just don't know. Somehow that connection and the response never made forth. There were things in the federal rules that called about trying to do some automatic redeterminations called ex parte redeterminations. That has helped some, but there are still large numbers of people in many states. I don't think it's happened quite this bad in Tennessee yet, that are losing coverage. The last that I saw in Tennessee, and so again, I could be wrong. The last statistics I saw in Tennessee, basically speaking, that Tennessee's enrollment or TennCare enrollment began dropping in June. And so the last data that I saw from the state was for July. There are about 15,000 fewer people on TennCare in July than there were in June. I would expect this to accelerate and to grow more and more. How many people in total are going to be lost from TennCare, or in fact from the Medicaid program nationwide? I'll be honest and tell you, no one's exactly sure. I mean, so I've been doing estimates related to this. I've seen a lot of other estimates, and the truth be known, we don't exactly know, because much of it depends on how effectively states implement the procedures, how effectively people come back and respond to Medicaid to say, here's the information that shows that I'm still eligible, I'm not eligible. And so we don't exactly know. An intuitive guess that many people think sounds about right is when all of a sudden after the unwinding is done, so this ought to conclude itself about a year from now, is the chances are enrollment will be roughly speaking where it was before the pandemic. So to the extent that we've seen in Tennessee growth of around 370,000 people between 2020 and 2023, a reasonable guess is roughly speaking that many. So maybe 300,000, maybe a little more, maybe a little less, will lose TennCare eligibility over the next year or so. This does not mean that they will become uninsured. The analyses also suggest, but once again, as someone who's an academic who does these things, performs calculations, their estimates, do we know that our estimates are right? We hope so, but we can't be sure. We do our best. But so the estimate suggests that actually the minority of people who lose their TennCare will become uninsured, that a very large number of them will get job-based insurance because in many cases, once again, the economy is pretty good, the unemployment rate is pretty low. So people took jobs in this time period. Hopefully many of them are getting job-based insurance. If not that, they can join the health insurance marketplaces once again. Under the legislation, the premiums right now are a little lower, a little more affordable for people. Some of the children can join the CHIP program instead. So the net effect is, of the roughly speaking 400,000 people who lose TennCare, how many will become uninsured? I'm not exactly sure. Maybe 100,000 to 200,000 more people will become uninsured. So it's still a pretty big number, but not all of them. So, that's the situation that we're in right now. And again, because of this, we're going to see some economic growth or economic loss. So we did some estimates of what was the effect of unwinding in Tennessee and in other states. We did this a couple of years ago. I'll say that I'm going to give you some numbers. I don't think these are right. If I had to redo these numbers now, I would probably say I think the impact is maybe roughly twice as large as I thought about a year ago. Part of that was because at that point, we expected that the public health emergency would have ended about a year ago. So when enrollment in Medicaid had grown less. In fact, it continued up until early this year. So that was why, TennCare continued to grow. It continued to grow in other states. Anyway, so I think these estimates are too low. Nonetheless, it gives you a sense. So we would expect that unwinding would lead to about 170,000 fewer people in TennCare. So that was what we said a year ago. I think that's too low. We would expect that would mean the federal government would put in around $580 million less into TennCare. The state would have some savings too. The state would save around $246 million, but there would be a reduction in the state economy. The state economy would fall by the tune of, roughly speaking, $2 billion per year because of this retraction. So this is something that is going on beginning right now, what I think will happen over the next year. So even though the overall economy is pretty good, again, right now I hear people in the news saying, are we going to have a soft landing, et cetera? Even assuming that, this is something that will mean the landing will not be quite as soft in Tennessee, because there's going to be, roughly speaking, this negative economic impact of unwinding. Related to that, there'll be, roughly speaking, 19,000 fewer jobs after 12 months. So there'll be some loss of employment. Again, less money coming into TennCare means less money being spent in hospitals, clinics, pharmacies, and so on and so forth. And so that means in the end, there are going to have to be some reductions in staffing. So that leads to, roughly speaking, in healthcare, around 5,000 fewer jobs. In other sectors, it's around 13,000 extra jobs. So this is something that we'd anticipate will be going on over the next year. And again, these numbers probably are not right. They're probably too low because our estimates were made under assumptions that aren't quite what actually is happening right now, probably higher than this. But this is what the current situation is in Tennessee, simply in this situation. So one hand, I want to put that contrast to you. If Medicaid was expanded, that would increase federal funding, contribute to the state's economy, would lead to more money in the state, more jobs in the state. To a certain extent, the growth that happened during COVID, the increase in the federal matching rate, the fact that people were kept on for Medicaid, was similar in nature to that sort of the Medicaid expansion. But right now we're going through an unwinding. And the unwinding will mean that we're going to see people being lost from Medicaid, lost from Med 10 care. And I'm sure that many of you are engaged in things trying to make sure that people respond to their new request, stay insured in 10 care, or if not in 10 care, get enrolled into other things like the health insurance marketplace, CHIP, other forms of health insurance, because that's a vital thing right now. So that's sort of some of the economics and the fiscal aspects of what's going on with Medicaid expansion on one hand, or what's going on with unwinding. Maybe before I stop, is there anyone who has any questions? I realize I went through a bunch of numbers. Yes.
You mentioned the American Rescue Plan. Is there an expiration on that? Like, do the states, Tennessee have to do that now, or do we have time?
The American Rescue Plan is written in such a way that it doesn't matter when Tennessee expands Medicaid. So there are a couple of states that have just expanded Medicaid, so that goes into effect. But if Tennessee did not expand Medicaid for another 5 years, the way the legislation is written now, that 2 years would begin at that point. On the other hand, it is still a 2-year limit. So again, it doesn't matter when Tennessee does it. I would wish that it did it sooner rather than later, because again, there's still these billions of dollars in federal government funding that could come to Tennessee that Tennessee is not getting right now. I mean, so effectively speaking, by not expanding Medicaid, not only are you not insuring people, or you're not only not helping people get health care assistance, you're also depriving the state economy. You're draining the state. So the longer you postpone it, the longer that occurs. On the other hand, that little American Rescue Plan bonus, the way the legislation is written right now, it doesn't matter when Tennessee does it. It would be true a year from now, it would be true 2 years from now, there'll be a 2-year bonus. Other questions?
Yes, I'm confused. Tennessee is saying they don't want to expand Medicaid because they'll have to pay whatever you said, billions of dollars, whatever. But they're paying for 10 care now, are they not? Where's that money come?
So they are paying for 10 care right now. So again, the state budget pays its matching share for Medicaid for 10 care right now. It is, on the other hand, true that because Medicaid is set up on a matching basis, that if 10 care is expanded, that state share will go up a little bit. Again, if it's the Medicaid expansion, it's a 90% federal dollars, 10% federal match. So the amount that extra state money is pretty darn small. I mean, anytime, frankly, if you offered me a deal and said, you know, are you willing to go buy, a new pair of socks? I will pay for 90%. You'll just pay for 10% of the cost of those. I would say that's a damn fine deal. Let me buy as many socks as I can. Nonetheless, that is not what the state has chosen to do. But so, yes, there is a cost to the state. What I'm trying to show to you, however, is though there's a cost to the state will get a lot more federal money. And because of that American Rescue Plan bonus, the state would have to pay, roughly speaking, $200-300 million extra a year in its matching costs. On the other hand, we'll get $600 or $700 million in a sort of fiscal bonus that will come directly to the state in that time period. So in the first few years, the state budget will be making a profit off of the Medicaid expansion.
Heard from our friends in Nashville that if you expand Medicaid, then employers are more likely to not pay for health insurance, especially those at the upper level of Medicaid eligibility. And then you put more Medicaid into the market, and you will have, at least with Tennessee, less provider acceptance and more healthcare dentists.
Sure.
And that's what started TennCare, is that we had a Medicaid program.
I remember
But
10 care in the
nobody-
90s.
But nobody would take it.
Right.
Because the pay was so.
Right.
The reimbursement rates really haven't changed that much. So if you expand Medicaid and less insurers pay, and then we will have more healthcare benefits. Is that-
So let me start out with first the basic gist of the argument, which is it true that if we expand Medicaid, fewer people will have other forms of insurance? And the answer is sort of yes. There's a phenomenon that we call crowd out. There would be some degree of crowd out, particularly to the extent that people are paying on their own for individual health insurance. They'll say, my God, if I can get Medicaid instead, boy, that's a better deal. On the other hand, to the extent to which there's reduction in job-based insurance, the evidence shows that when this has gone on in other states, this has not particularly been the case. There is some reduction because yes, there will be people who are on the job right now and who, if they are on the job and they're a low wage person, you're asked to pay $50, $100 a month in premiums, and you find instead you could get Medicaid for free, then a lot of them say, yeah, boy, if I can get it for free, why did I need to pay that $50 to $100 a month in premiums? So there's some loss. But on the other hand, is this sort of create more people with employers to drop out of the market? That doesn't appear to be the case. There's a certain, there's been some slow gradual leakage of employment sponsored insurance for many years. That was actually one of the things the the Affordable Care Act tried to help resolve, and that seems to be working. That has kept the rate of the offers of employer sponsored insurance up pretty high. So that isn't true. Now to the second part, and this is the touchier part. And here, you've lived this better than I have, so I can't recall. The early expansion of TennCare was something that was very noble, an effort, but didn't work out very well at all. And I remember for a while there, back in the 90s, TennCare was on the headlines every single day. And I don't mean in the headlines in Tennessee, I mean the headlines nationwide. There were good things, there were bad things to them. Now, part of the reason that that happened was that that was arranged in such a way that Tennessee was trying to do this under a Section 1115 waiver that was budget neutral. That essentially speaking, Tennessee, and there were some funny things that had to do with dish money, et cetera, et cetera. But basically speaking, they were trying to take the amount of money that TennCare got right then and expand it over a much larger pool of people, and tried to force healthcare providers to take funding when rates weren't very good. And that's what led to the problem. Under the arrangements that are going on right now, there would be new federal money that would come in. This would help sustain that, so you wouldn't have to see that sort of trying to serve 3 times as many people with the same amount of money. There would be a growth in the amount of funding. This does not mean that Medicaid rates would suddenly become pie in the sky high. In fact, I don't think that's going to happen at all, but they would not have to be cut. And there wouldn't be this cram down that occurred. That was the lovely term that occurred back in those early TennCare days. I don't think that would be occurring then. So I think the tragedy that occurred back then with TennCare is not something that would happen now. Again, we have now seen a Medicaid expansion go on in the great majority of the states. And what happened in Tennessee then is not what's happened in any other state. It's probably not, well, I won't say is not what would happen. It was because of the funny circumstances of how the TennCare deal was struck then. And I know and love Gordon Bonnyman and some of the others who were involved in the architecture of that deal. But it was an overly ambitious plan and underfinanced. The current Medicaid expansion would not be set up in quite that way. It's really set up to be beneficial to states and the healthcare providers. And so we've seen actually in states where Medicaid expansion has occurred, there's actually been some influx of more people come in to be primary care providers. They realize this is a good place to practice. So that's all beneficial. Impact of Tennessee block grant. Okay, so there were a couple of questions that came in, and if you don't mind, actually, maybe let me try to sort of finish off the talk that I have, and then I'll come back to these questions. Okay, so sorry for those of you who are on Zoom. I'm near the main part, but then I'll open it up to questions in general. Anyway, so next I want to say again, I'm a healthcare person. I'm in public health. I care about these things. There are literally hundreds of studies that show the benefits of Medicaid expansion. So there should be no question that Medicaid expansion has helped reduce the number of uninsured people. So there was this concern about crowd out. Is there some situation where somehow, as we expand Medicaid, it's self-defeating because more people will lose private health insurance? No, that's not true. We've reduced the number of uninsured Americans by substantially because of Medicaid expansions. It did expand access to general medical care, to mental health care, to dental care, some things that people care a lot about these days, to opioid treatments. We've seen increases, there are major expansions, and we can compare the states that expanded Medicaid and the states that didn't. And we see that the amount of funding that go in for opioid treatment soared in the states that expanded Medicaid versus the states that did not. It has narrowed racial ethnic disparities in care. So one of the great tragedies in the US is that we know that the proportion of Black and Latino Americans who are uninsured, who have poor access to medical, mental, and dental care, there's some big differences. When we've expanded Medicaid, we have managed to narrow those differences. Now, but I will say that's sort of a tragedy that the states that have not expanded Medicaid are largely southern states and some other states that have relatively high proportions of Black and Latino residents. Florida is one of the states that has a lot of Latinos. And that effect is actually, if those states could expand Medicaid, we would really make a big dent in narrowing those racial ethnic disparities. And sort of the fact that Medicaid is not expanded really has sort of been one of the things that contributed to racial ethnic disparities continuing in the US. This is really a problem. So we know there's research that says it saves lives, it reduces mental health problems. People express fewer problems with depression. It has improved care for diabetes, cancer, cardiovascular problems. So from a health perspective, forget the finance stuff. But actually, don't forget it. But it's a good thing from a healthcare perspective. There are other social and health benefits. It helped, again, respond to things like the opioid crisis and frankly, COVID. Because of COVID, Medicaid was helping to sort of provide not only things like, COVID vaccines, but also treatment for people who got COVID. So it helped lower uncompensated healthcare costs. Where this is important is for safety net clinics, for rural hospitals that have been staggering in many cases because of problems with uncompensated healthcare costs. It helped lower those things. And so the net effect is it helps sustain rural hospitals. And I realize this is something that counts for a lot in states like Tennessee, is where there are some rural hospitals that are having financial problems. And again, I'm sad to say, because of this unwinding that's going on in Medicaid right now, where we're going to see fewer people have Medicaid over the next year, it's going to intensify some of those problems for rural hospitals. It's going to intensify some of the problems that community health centers and other safety net clinics have. So I'm sad to say that that's going to happen. Again, Medicaid expansion could help counter those things. But there are other sort of broader things we've sort of, in addition to that, helped improve financial security. There are some studies that basically show there are fewer people who have financial problems, who express problems. People are better able to avoid medical debt, better able to help pay their mortgages, to do other things. There are even some studies, I'm not sure I entirely believe them, but say basically things like there are fewer people who are having their mortgages foreclosed, fewer people who are going to jail because of the Medicaid expansion. Again, some of it, I'm not sure I necessarily believe all of it, but there could be fairly widespread social effects that are beneficial too. So, and now maybe let me take a pause for a moment to deal with some of the questions that came up, and there were some that came before, and there's some more now. Anyway, let me deal with the first one. Can I talk about the Tennessee block grant in any way? I must admit, I don't know the details of the block grant proposal that went forward. I do remember that Tennessee was a state that just in the last waning days of the Trump administration said, we want to propose a block grant, and the Trump administration hurried this proposal, the waiver approval yet, and basically approved it for 10 years rather than the standard 5 years. And that the Biden administration then came in and said, we would like to reconsider some of this, and we would like to rethink of it. And I gather there's have been some important changes within the past week. I suspect that many in this room understand that whole arrangement better than I do. So I'm not going to talk about it in much depth, except to the extent that we know that block grants historically create a problem. And the problem with block grants is the key in block grants is basically the deal is states say, we will give you, we'll agree that we'll cap federal costs, and in return, federal government, please give us more flexibility. And the problem is that in many cases, there are problems because of the economy turns down, because of problems like COVID, that healthcare costs go up and the state can't help avoid it. I think maybe there was something in the 10-care waiver that tried to deal with that, but that's a problem that unfortunately it caps growth. Analyses that have been done tend to show that block grant arrangements would be harmful to states, that in end would lead to states having to cut eligibility, cut benefits, despite the fact that the state might say, no, 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 we won't do that. A next question. So again, some of you probably know the answers better than I do. Another question is, we can get county by county data on gaining 10-care, and so on and so forth. So I'll be honest, say we could do analyses like this. It costs some money to do the analyses. So in order to do this, we have to basically go sort of purchase or rent the software to do this. It's not cheap. So I don't want to put a price tag on it, but if people want to talk, we can. It is feasible to do. On the other hand, it's not as though it can be done for free. A next question that comes up is, some states collected data on the number of employers who have 10-care enrollees working for them. Do we have any estimates on that from North Carolina, from another conservative state? I don't know the answer to that. So I don't know. There probably is some data that exists or could be tabulated somewhere on employers who have 10-care enrollees working for them, but I don't know off the top of my head. Do I have any studies that looked at how expansion kept people from working and got them back into the workforce? So actually, this does bring me to my next topic, which is Medicaid and work requirements. So one of the things that has been proposed in many cases, including in Tennessee and including some other states, was the notion of adding in Medicaid work requirements. And I will say, I understand the gist of people who basically say, why should we give some people money, something for free? Shouldn't people have to work in order to sort of get these benefits, whether we're talking about Medicaid or food assistance, the SNAP program, supplemental nutrition assistance programs, or welfare benefits, TANF. So I understand that perspective of why people say that. We say, we're a work-oriented country, and so we should require that people work. On the other hand, I will say there are particular problems about this with respect to Medicaid. And in the case of Medicaid, at least when this came up in a legal perspective, this went to a federal court. And the federal court basically said, when the Trump administration permitted work requirements to begin in states, that was illegal, that it had done that invalidly, that there were no provisions in the Medicaid statute that said work requirements could be added in as an eligibility criteria, that this violated the underlying concept of Medicaid, which was to help more people get insurance, that in fact it does the other thing. So we only actually have one actual experience so far of work requirements, and that was a brief attempt where it existed for a few months in Arkansas. But we know from the few months where it occurred before the court shut it down, it was very chaotic. Roughly speaking, in a few months, 18,000 people lost Medicaid coverage, and there were no job gains. I mean, that's the other thing, is when people say when you have work requirements, more people will find employment. And so in the end, it's a good thing for people. It's a tough love perspective, that this will help people go find jobs. There's virtually no evidence, and I'll talk about this a little bit more, that shows work requirements in Medicaid or other places have led to substantial increases in employment. And again, the one experience we saw in Arkansas was it was very chaotic, it was very confusing, a lot of people lost coverage. So in contrast, there were some similar efforts in the state of Montana to basically say, we would like to encourage work in Montana, so we will do things to encourage this by offering more job training, by doing more things to help people get jobs. That was successful. So that wasn't using a sort of whip approach. It was trying to say, let's help people find employment. Let's do more things to help them find work. That approach can work. So there are reasons to think there are alternatives that can still have that effect of helping to gain employment for people who don't have employment. But the truth be known, and I'm sure all of you have heard this, is typically speaking, and I can't swear what the statistics are in Tennessee, the majority of people who are on Medicaid, these adults, are working already, at least some. In many cases, the reason they're not able to work more is other things in the economy, but also in many cases it's individual problems. They have children or other dependents they have to take care of. They have disabilities that keep them from working. They don't have a functioning car, so they can't get to work. So there are all sorts of things that are barriers. In many cases, they don't have the sort of educational skills and background that would get them good, decent jobs, that would get them private health insurance. So the work requirements basically say people have to work, but doesn't sort of mean that they would find jobs that have health insurance. So the state of Georgia is beginning work requirements again. It has under a funny waiver. It also had a waiver that had been approved by the Trump administration that coupled the work requirements with an expansion of Medicaid in Georgia. So that one, CMS said, okay, we're going to let this run for a bit. So this has just begun. So far, the data that we have from Georgia is very slim. Georgia had anticipated when they began their program, they began this in July, that they thought they were going to get 100,000 new people enrolled in Medicaid. The last data that I saw said that 265 people had signed up. So way short of that expansion that occurred. We have not seen people cut off of Medicaid yet. The 3 months, typically speaking, the rule is you have to be working for at least 80 hours a week for 3 months, and then you get cut off. So the 3 months has not occurred yet. But inevitably, we would expect that some people would get cut off. So this is where we know a little bit more. And by the way, tell me if I'm going on too long and I need to shut up. I saw someone holding up a sign, so maybe that's just sort of a yank me off. So let me hurry up a little. So we know from studies in the SNAP program. So the SNAP has had work requirements for many years. So we have a better basis for research on that. In fact, some of my colleagues and I have done research about what happened with SNAP. And so what we do know, and we looked at the data from basically across the country in the pre-COVID years, that basically speaking, when SNAP work requirements went into effect in a state, within 3 months, those states had lost about 1/3 of the people who were subject to the work requirements. So there were no particular gains in employment, but in fact, about 1/3 of the people lost coverage. That in addition to this, the people who lost coverage, the rate of SNAP loss among Black adults was about 3 times the rate for white adults, despite the fact that once again, under SNAP, the policy was that disabled people are supposed to be protected. Disabled people also lost benefits. It was very hard to sort of keep that disability protection functioning. So the reasons and so this is this is not just some fluky thing that happened in one state. This is basically across the country over many years, problems that were occurring. And this is actually despite the fact that SNAP actually did include in some employment and training funding, which typically has not been the deal in Medicaid. So there are perfectly good reasons to think that work requirements, really what they do is they end up cutting people off. They might have some small increases in employment, but they typically speaking are not sustained. So mostly they are ways of cutting the caseloads. And that's actually the intent of the people. The additional element of this is it's because the people who get cut off are the people who don't have job-based income. What does this mean? It means the people who get cut off are the poorest people. The people who have the least ability to buy groceries on their own, the people who have the least ability to pay for healthcare on their own. So that's the other particular sort of troubling aspect of work requirements, is it really hits the people who are the poorest the hardest. Anyway, so there's a lot of data that basically show work requirements don't do what the advocates for work requirements say. That being said, I understand why from a rhetorical perspective, work requirements are popular. So I'm trying to sort of wrap up, given that I was getting a high sign. So what I hope that we really need to move into is a situation where we can sort of move into a less partisan situation. We need to grow past the ideological and partisan divides that have occurred. And that has occurred somewhat already. So you may remember when the Affordable Care Act was first passed, the deal was that every state would have to expand Medicaid. And then in 2012, the Supreme Court basically said, no, states have an option to do so, yes or no. One thing this helped created more of a problem for Medicaid expansion. On the other hand, the good thing was it actually forced states to make a decision. Are we going to go forward or not go forward? So at the point that happened in 2014, when the Medicaid expansion first took off, the dominant share of the states who expanded Medicaid were states that had Democratic governors. Since that time, 12 states have expanded Medicaid since 2014. Of that, 8 of them are states that had Republican governors. 4 of them are states that had Democratic governors. So we've seen something in situations in which this can be acceptable in states that have strong Republican majorities, that they've recognized that this can be beneficial. I will say in some of these cases, this happened because there were referenda. It's not as that the governor necessarily supported it, him or herself, but nonetheless, the voters did this and the governors went along. So we can see this. We can see that expansion has tended to be popular when there's polling that's done. Medicaid expansion tends to be popular not only with Democrats, not only with independents, but also with Republican voters. So when I've seen polls that are done, surveys, it's actually about, maybe 2/3 to 70% of the public, including majority of Republicans, support the concept of a Medicaid expansion. So again, we know the situation in North Carolina, Republican dominated legislature appears to be ready to go through. So all in all, what we've seen is that roughly speaking, 2/3 of the states that have Republican governors have had a Medicaid expansion. Has this been a disaster for states that were Republican states? No, it has not been a disaster. And in fact, 2/3 of the Republican governors have states that have expanded Medicaid. So this was something that should no longer be the partisan issue that has been, generally speaking, across the country. States that have had strong Republican governors or legislatures have seen Medicaid expansion go through, and it was not the disaster that people thought. So there are a lot of unfounded criticisms of Medicaid expansion. We've heard some of these things. States are going to bankrupt if they expand Medicaid. There's going to be this huge crowd-out problem. The healthcare system will crash. Doctors will leave like crazy. And then the other thing that happens is people often say, there's this 90% match rate that's built into the expansion. If we do away with the expansion, Congress will pull it away. It's a bait and switch situation. So that consequently, the states would be holding the fiscal bag. And the answer is that's extremely unlikely to happen. In fact, it won't happen. Since 40 states have expanded Medicaid, 40 states take advantage of that 90% match rate. There is no way that in Congress you could pass legislation that would sort of take away that match rate. That would hurt basically 40 out of the 50 states. So it's not going to happen. So what I'm hoping that we can have, and hopefully that's part of what you guys are trying to do, is develop a new alliance for Medicaid reform. So traditionally, the alliance that happened for Medicaid reform was it came to sort of, a group of people that were alliances of people who were health and social advocates, labor, civil rights advocates, healthcare organizations, and then frankly, Democrats. What I think that hopefully we could see is an expansion of this and sort of trying to go into other groups. And particularly, I would say you need to include businesses in the alliances, particularly chambers of commerce. Chambers of commerce can be convinced that this is economically good for them. And in many cases, actually, healthcare organizations are powerful members of local chambers of commerce. So this is what I've seen happen in some of the states that have sort of decided they could expand Medicaid, is chambers of commerce to say, we think this is a good idea too. And so that gets at a core traditional mainstream support source. But in addition, you can have religious groups, independents, and hopefully you get moderate Republicans on board too. So I think there is a way that this could be done. I'm not going to say it can be done easily. Again, I've been working in the state of North Carolina for more than a decade, and I grew up in Texas, so I still think of myself a Texan. Tennessee will expand Medicaid long before Texas does. But even in Texas, I hold out hope. So I think it's possible. And so it's through efforts of people like you that you can begin to do this. And then hopefully the economic argument is not a slam bang argument that will solve it for everybody, but helps deal with some of those fiscal concerns that people come up, and helps deal with some people who say the real problem is we can't afford it. The real answer is you can't afford not to expand Medicaid. Expanding Medicaid is a good deal for states. It is too good a deal to pass up. And so if you're not doing it, basically speaking, people are sacrificing the welfare of their states for ideological purposes. I think that's the end of my talk. Oh, reframing. So same deal. we need to sort of learn how to reframe the debate to sort of try to have this aspect in which we're showing there are multiple benefits. It is not all, ideological. Yes, it's important to have the healthcare arguments, it's important to have the moral arguments there, but to the extent that you can have economic arguments that you can try to say, this is going to help businesses, this is not just going to help healthcare, this is not just going to help poor people. And I'm sad to say, because this is the way it is often, it's not going to just help Black people. Then this is something that helps build a broader coalition that can help create the sort of necessary force eventually, and I can't say this is going to happen anytime soon in Tennessee, you guys know better than I do, that can lead to these expansions. We've seen this happen. Again, since 2014, 12 states have expanded Medicaid. North Carolina is on the brink of expanding Medicaid. There can be gradual changes that occur over time, and it's through people like you and the goodwill and the efforts of people like you that this can happen. Thank you very much.
Thank you. Here's a little memento of your visit to Tennessee.
Thank you so very much. And hopefully you can figure out how to get the
Watch.
projector working again.
Wait,
Yeah, I don't want to pull it all out. My foot is clear now.
So now we need to divide up the room. So Judy, do you know which event is happening in which half?
Let's put rural hospitals here and here.
Okay, so the ACE from a Black perspective will be on my right side, your left, and the rural hospitals will be on my left, your right. And we'll get started as quickly as we can. One thing I forgot to mention was that for those who are doing their CEUs